Hello, everybody. Welcome to the first edition of US Skyline. On the other side of the screen, you can see my friend and course co-director, Skalk van der Merwe. Hi, Skalk.
Good morning, Alberto. Good morning, everyone.
Everything is okay on your side?
Everything is perfect, ready to start.
Some people ask me why US Skyline. Basically, the answer is very easy. About more than 1 year ago, I was with Skalk in Leuven in front of a Leffe beer, and we were talking about, about US in general and about the concern that we have that in big events, in big endoscopic events, US procedure were always put sort of on the corner. But nowadays we have new accessory, new indications, new procedures. So we thought that this was the right time to develop an event completely dedicated to diagnostic and therapeutic US.
Yes, I think you're absolutely correct, Alberto. I think that endoscopic ultrasound, and specifically therapeutic endoscopic ultrasound, has become of age. These techniques have now been incorporated into clinical guidelines. They are used all over the world to help patients and improve patient outcome. So I think that it's very appropriate that we dedicate a session to therapeutic endoscopy, where we can show these procedures as they are done all over the world by experts.
We have a very tight schedule. But before we start, I want to make some thanks. I want to thank the team that worked really very hard all year long and made this possible. I want to thank the moderators and the endosonographer that participate to this event. Some endosonographers that accepted to work with the endoscopes that are not used to use. I need to thank the sponsors because without the sponsor this will not be possible. I want to thank in advance who will connect to the event that is very important for us. And finally, I want to give a special thank to Alessandro Repici and Thomas Roche, who basically started this business and even before the COVID was started. So they paved the road to live web-based events that, in my opinion, are here to stay because we have the COVID, we have strikes of the plane. So nowadays it's very difficult to organize a big event in person, and I think this is the way to go. And also, if then we have COVID in some of our faculty, so we have to make changes. So the schedule has changed a little bit if you compare with the previous one, but we made everything to do our best. So we start with a great, I think, a very famous and great US diagnostic endosonographer and a friend, Masayuki Kitano from Wakayama, Japan, who will be moderated by another king of US diagnostic procedure, that is Adrian Saftoiu from Bucharest, Romania. So Adrian, are you there?
It's my pleasure to introduce the first speaker, which is Dr. Kitano. So I think we will see a very nice case of diagnostic applications of US. So please, Dr. Kitano.
Okay. This is transmitting from Wakayama, Japan. My name is Masa Kitano. I performed the EUS procedure together with two of my colleagues, Dr. Reiko Ashida and Yasu Yamashita. So please show the slide twice, please. First of all, I appreciate Professor Alberto Raggi for giving me this great opportunity. I'm very happy to show you and the endosonographers all over the world. The case is the 8 years old female. She underwent thyroidectomy due to thyroid cancer. The abnormality depicted very low echoic, a very small lesion with high dense with dilated duct. Tumor marker was negative. Next slide, please. During the follow-up of CT scan of whether the occurrence of recurrence of thyroid cancer. First of that image shows, left image shows, no tumor, I mean the left image, no tumor at all in the 2018. However, you can see the pancreatic parenchyma is a little bit atrophic. In the recent report, we reported that pancreatic atrophy is the risk factor for predicting of future occurrence of pancreatic cancer. And then, please look at the right image. You can see low density tumor-like lesion with dilated duct. In this session, I would like to show you EUS elastography and contrast enhancement. And after that, we perform EUS FNA for this suspected lesions. So please show the image, endoscope image, please. Okay. We have already inserted the scope. I use the Olympus UCT 260 as well as Arietta 850 for the image analysis. Please change to the image to the endoscope EUS ultrasound, please. Change to the image. The tip of the scope has already inserted in the gastric body. EUS に書いてください。はい。はい、OK。ちょっと電話上げようかな。はい。Can you see the image of the sun?
Yes, perfect.
Okay. I'm observing the low echoic area at the pancreas body. You see? The low echoic area is measuring is approximately 90 millimeter. I'll show the diameter first. Please show diameter of the tumors. Right, okay. Approximately 90 millimeter. And then you can see the dilated duct as well, adjacent to the low echoic area. The pancreas duct is dilated toward more than 10 millimeter. I turn the scope clockwise, you can see the dilated duct. And turn the scope counterclockwise, I can see just low echoic area. And then furthermore, I can see ordinary pancreas parenchyma as well as portal vein. Then, time is limited. I will perform the elastography first. In the right image, you can see colored image.
Could you please explain a bit what kind of... Dr. Kitano, could you please explain what kind of elastography and if you're using both strain and shear wave?
In this case, we use strain elastography only. So far, shear wave elastography is not so useful for the evaluation tumor-like region. So therefore, for this case, I use the strain elastography. In this image, you can see the tumor has blue color, together with slightly blue, green, and red area. Blue means the low strain, which means the hard tumor. So therefore, it is suggested with the pancreatic cancer. In the meta-analysis, shows that strain elastography has the more than 95% of sensitivity as well as 17% specificity. The sensitivity is quite high, but specificity is not so high because some chronic pancreatitis cannot be excluded. So therefore, I have better perform contrast enhancement as well as USFNA. So please change the contrast enhancement mode first. Okay. Before perform the contrast enhancement, you can see the monitor mode in the left image, and also quite a dark image in the right image. It means this is no contrast enhancement. Before perform the contrast enhancement, I also perform the screening of liver metastasis using ordinary EUS. This is a conventional standard EUS in the liver. Please change to the contrast enhanced mode. You see the black area, black image in the right image. It means no contrast in the liver. After contrast enhancement, you can also observe contrast enhancement in the liver. I mean the Kupfer image. Kupfer image means that we use the ultrasound contrast sonazoid for this contrast enhancement. Sonazoid remain in the liver more than 1 hour. So therefore, after performing contrast enhancement in the pancreas, we look at the liver, whether the liver metastasis exists. So perform contrast enhancement for the pancreas.
Could you please tell us the dose, Dr. Kitano, what dose are you using for Sonazoid, and if there are advantages as compared to Sonoview?
Compared to Sonoview, the dose of Sonazoid is less because we usually use less than 1 millimeter. Usually we use the 0.7 millimeter, something like that. Unfortunately, I cannot catch the expression, so I perform the contrast now. You see, no contrast. It means no black area. We use the Sonazoid. Please show the Sonazoid. This is just 0.7 ml. So we infuse it. Oh, please, now we counter, please. You can see the counter at the upper left portion of the image. Now 9 seconds, 10 seconds, 11 seconds, 12 seconds. Then you can see the vascular image of the tumor. Immediately after infusion of the ultrasound contrast, you can see the contrast homogeneously distribute to the tumor. However, we usually look at the image at 60 seconds after infusion. It is now 47 seconds after infusion. You can see that area has the low density compared to the surrounding pancreatic parenchyma. So the tumor also has the vascularity. However, the contrast enhancement has the lower image than the surrounding pancreatic parenchyma. So it is suggestive of pancreatic cancer. Then I go to the liver. You can see Kupfer imaging of the pancreas. You see right image. Compared to the previous image, before performing contrast enhancement, you can see white liver of the white parenchyma image in the liver. It means the liver still contains the ultrasound contrast. ちょっとね、ディープにしようか。ファーディープで。弦上げて。はい、OK。So I perform screening of liver metastasis using single mode. I'm accept any questions.
Okay, so it looks a bit hyper-enhanced.
Yes.
Okay, it looked a bit hyper-enhanced in the arterial phase. On the differential diagnosis with neuroendocrine tumor, maybe?
Yes, in the neuroendocrine tumor, vascularity remains even in the 60 seconds after the infusion. So it means hypervascular. So I will perform the USFNA in this region now. For the USFNA, first I use Olympus EG Shot 3 Plus, which has the pierceability of the, which has high pierceability of the tip of the needle. I mean sharp. If I have time, I would like to perform 2 sessions of USFNA. First, I use Olympus EG Shot 3 Plus. Later on, I would like to perform USFNA using USFNB using sharp needle. I think I had better carefully puncture of the lesion because the dilated duct is very close to the puncture line. You see, this is a dilated duct. We shouldn't puncture this lesion. So I had better rotate the scope counterclockwise to avoid the puncture of the dilated duct. Maybe this one is suitable for the puncture. ちょっと消してもらおうかな、ライト。ライトですね。はい。Maybe I had better rotate the scope counterclockwise. Otherwise, I may puncture pancreatic duct. Maybe I think this is a suitable caution. Some cystic lesion also there. Maybe I also have better avoid this lesion. Dilate duct. Rotate counterclockwise. Okay かな。Can you see the image of the needle?
Dr. Kitano, I'm Dong Song.
Oh, Dr. Seo.
Yes.
Yes, I can hear you now. I use the.
You can see clearly the nice puncture of your needle through the mesh-like lesion.
Okay, thank you.
You mentioned that you will do FNA first and then you will add FNB. Is it your usual practice?
Yeah, I usually use only 1 needle usually. But Alberto requested me to perform 2 needles. First I use FNA needle and then I use FNB needle. If I can use 2 needles, maybe I had better first use the FNA needle because it has a higher pierceability in such kind of very small lesion. So therefore I chose FNA needle first in this region. But if I had better use only 1 needle, I use the FNB needle first. Do you think is it correct, or do you perform the only FNB?
I think that is a reasonable approach.
Morning, Dr. Kitano.
This has a very small lesion, so I have to be careful to use the needle back and forth. Otherwise, the needle can be retracted, removed.
Dr. Kitano.
Yes.
Good morning, with Scott and Member from Leuven. I just wanted to ask you, I see that there are some cystic changes around the tumor. Do you think this can fit in with a transformation of an IPMN?
It's difficult to say, but I guess it is just retention cyst.
Okay.
Due to the tumor, I think.
Yeah.
I move the needle back and forth, probably 20 times, something like that, because this is a very small tumor. And also, I have to be careful to perform this. If the needle is moved a lot, maybe needle tract sealing also risk factor of this kind of tumor, because I puncture the tumor from the gut body.
It's a beautiful demonstration. It really is great to be able to visualize the needle so clearly as it passes through the tumor. Beautiful.
Yes, we have to keep the tip of the needle in the tumor anyway. All right. So then I retract the needle, and we usually perform modes as well as rows, because we can, Dr. Ashida, Dr. Yamashita can perform rows by ourselves without any site pathologist. In our unit, we have the system of rows. We using the microscope, and then first we use the modes. Please show the modes. The tumor has the size of the tumor is very small, so maybe the volume of the sample seems small, probably. So we look at the image of the modes. Maybe this is the last image, because the 2 minutes, only 2 minutes. Dr. Ashida, please explain.
Yeah, we can see a small fragment of the tumor. So usually we will push out the tissue into the liquid biopsy fluid. Maybe it's difficult to see. Can you see? So we can see the very small whitish fragment. Because this is an FNA needle, it's kind of difficult to get many tissue. So now we will switch the needle to the FNA needle. Can you see?
Yes, are you still performing slides? Are you still performing slides or only liquid cytology?
Yeah, if we have a lot of tissue, I'm going to perform the rows. But for this case, I cannot see enough tissue, so maybe I will send this all of tissue to the liquid LVC examination. Then we will use the second tissue for the rows. Okay, thank you. So now Dr. Kitano is performing a second answer.
I have already punctured the tumor using sharper needle. I don't feel any resistance, even in the FNB needle. So far no difference between 2 needles for the technical point of view. I have already attached the syringe for the negative pressure. I move the needle like the previous one. Anyway, in such small lesions, I had better move the needle very gently. Otherwise, the needle is coming out from the distal part or proximal part of the tumor. And also, I had better avoid the main puncture duct. So therefore, I puncture the area. I mean the area of the tumor close to the papilla.
Dr. Kitano, is there a reason why you don't use the fanning technique? Is it because the lesion is so small?
Yes, please. Yes, it is correct. Because this is a small region, I just move the needle within the 1 centimeter. And anyway, I use the fanning technique like this. Fanning technique. Right side, and the upper left side. All right. I don't think any difference between the FNA needle or the FNB needle between the maneuverability of the needles so far. I use the.
Dr. Kitano,
Yes.
you apply the negative pressure. Is it usual practice when you are doing
Yes.
FNB?
Sometimes we use the slope technique in the hypervascular tumor, like neuroendocrine tumor or something like that. But for the pancreatic cancer, I usually use this negative pressure using 10 millimeter or 20 millimeter. All right. Okay.
Yes. Hi, Mazat. Really, thanks for your demonstration. I don't think it was an easy lesion to puncture, as demonstrated by the fact that it was not easy to do the fanning technique. We need to move to the other case, and we have a small break before the second case. Thank you, Mazat. Thank you very much.
Thank you very much, everybody.
And thank you, Adrian. And thank you, Adrian.
Hello, can you hear us?
Good morning. Welcome back, everyone, to this live session. The next case will be performed by Dr. Pranjal, and that will be a demonstration of the drainage of a symptomatic pseudocyst. So Dr. Pranjal comes from Bangkok in Thailand, so welcome, and please proceed with the case.
Okay, hi, good morning. This is afternoon in Thailand, but good morning to all of you in Europe. I am here. My name is Pranjal Kongkam from Chulalongkorn University, Bangkok, Thailand. Can you hear us well? Yeah.
Absolutely. Welcome.
Okay, good. And I'm here with my colleague, so please allow me to introduce my colleague, my young junior, Dr. Thanawat, and my nurse, Brother Mu, who will help us, and also Dr. Vidyaporn behind the scene, and all my GI fellows are preparing cases today. So first of all, I'd like to ask Dr. Dear, who is my current US fellow, to present our case. So please.
Case of 22 years old male with severe necrotizing pancreatitis from hypertriglyceridemia 2 months prior. 1 month from the pancreatitis event, he started complaining of early satiety and abdominal distension. Abdominal CT show large multiloculated peripancreatic fluid collection, size about 20 centimeters, extending into left paracolic gutter. So today we schedule him to do the EUS-guided drainage with double pigtail stents.
Okay, thank you very much for your presentation. So today I will perform the procedure with J10 Pentax 4mm shunt therapeutic channel with area 65. At the beginning, like Dr. Dear said in the presentation, that we plan to do the plastic stent for drainage. However, now my focus in the stomach of the patient. And if you can see the content of the patient at this time, I will minimize zoom out, and then you will see the content of the pancreatic fluid collection. Actually, it's look like solid content, and there are some area of the necrotic debris. So actually, from the US finding, it's not pseudocyst, it is more pancreatic wall of necrosis. So then we change our plan. So we will use the lumen opposing metal stent for drainage. So for lumen opposing metal stent that we will use today, we will use a 20mm hot Axios, which is a lumen opposing metal stent, 20mm in diameter with all-in-one coagulation device. So actually, if you look at the EUS finding, you will see that the lesion is about 10 centimeters. In diameter, and it's quite big. So normally to drain this one, we don't need a guide wire in. We just use freehand. Hot Axios should be fine. But sometime after the procedure, there might be some local complication of bleeding because of collapse of the pancreatic fluid collection, causing subsequent bleeding. So today we're going to place a guide wire through our lumen opposing metal stent. So and then we can use this guide wire for plastic stent placement inside the lumen opposing metal stent. We use the lumen opposing metal stent because we plan to do direct endoscopic necrosectomy after that. So first of all, I take a cap of J10 out, and then I ask my assistant to send me the lamps, hot lamps.
Can you give us some information how you decide when to place a plastic stent compared to when you would place a lumen opposing stent? How to make that decision? In this case, it's clearly a walled off necrotic collection, but do you use other features, other cues before you decide?
Yeah. So I
the process and other features.
Okay, so actually, if we see the content that is very clear and purely cystic and no solid component inside the pancreatic fluid collection, we will use the plastic stent. The benefit of plastic stent over metal stent is that we can leave for lifetime for plastic stent. So we can leave the cystogastrostomy stent open. Even the patient have unfixable pancreatic duct leakage after that, and then we can create a cystogastrostomy for good. So that's a good thing of the plastic stent in addition to the much lower price comparing with the metal stent. But if the patient has necrotic and thick content inside pancreatic fluid collection and becomes wall of pancreatic necrosis rather than the pancreatic pseudocyst, so in that case, we anticipate that we need to do direct endoscopic necrosectomy in the near future to clean out all the debris from the wall of necrosis. So in that case, we'll use lumen opposing metal stent because we want both stomach and want to get together, and then we have to make the lumen big enough to insert gastroscope to do direct endoscopic necrosectomy later. So the diameter of the lumen opposing metal stent must be at the very least about 15mm in diameter. Today we chose 20mm because it's just available in our unit today. So larger than 15mm should be fine. I hope I answered your question. Is that right?
That is absolutely fine. I just wanted to know as well, do you think that this collection is infected?
This is a solid components and debris, but the patient does not have a clinical infection yet, but we do anticipate that anyway we need to do the direct endoscopic necrosectomy to clean it out to prevent or eliminate a possible infection that might happen in the future. Yeah. So for the procedure, I drop the scope into the stomach, and then we identify the pancreatic fluid collection and it's worn. So you see in this image that there's a hyperechoic solid component inside. There's a dead tissue that make this PFC to become a pancreatic wall of necrosis. And then I will turn on the color flow. Just want to make sure that there is no intervening vessel between the device and the wall of necrosis. So which now I place the hot Axios in, and then I lock it already. So then I will show the first step. We will connect the coagulator, which today we use Herbe Vio 3, and we use auto cut mode or pure cut mode to make a hole. And the next step, we will make the shaft of the device open, that we can pass the device here. And you see in the ultrasound image here, the device is here. And then just want to make sure again, we do the color flow, make sure that there is no flow in between the device and the wall of pancreatic necrosis. And then we turn it off, and then make sure that our scope in a good position. And then I'm going to go in with a coagulation device in here. Okay, we are now in already. So then the next step, we're going to push this one in, and then we lock the first step, and we take the yellow bar out, and we open the second step to open the distal flange.
Can you give us some tips and tricks if the connection is small and you have to open the distal flange in multiple steps?
In that, we have to adjust the black device while we are open to make sure that everything inside the lumen, particularly when we do something like in small area, like a small bile duct. So now here, I'm opening here. Now I'm almost completely open the distal flange here, and then come to the dash line, and you hear the click. And then we lock it, and we go back to the controller of the sheet. So then now the next step, we're gonna pull back the device all the way back to bring the wall of the pancreatic wall of necrosis close to the stomach wall. And now we will look at the endoscopic screen and control the control the device just a little bit and pull the scope back a little bit until we see the black line.
So you always rely on the endoscopic view.
Yeah. At this time on the endoscopic view, there might be some techniques that some people might use intra-channel, but I think because now today we use J10, which has more forward viewing, so now you can see the black line. So once you can see the black line, now you can open the distal flange, the proximal flange, like this. Oh.
That clearly looks like pus coming out.
Yeah, pus coming out. Okay, and then we will push the scope, adjust the scope just a little bit.
Beautiful.
And see the opening here. So a lot of pus coming out. So now what we're going to do, we're going to exchange with the guide wire to place the plastic stent. So I take the black this infuser out first.
Can you just tell us, is your patient intubated?
Yeah. And then now we unlock and we keep the exchange. And the next step, we're going to place a double pigtail 10 French medical stent to keep the track open to prevent the collapse of the wand to the lamp.
After how many days will you perform re-imaging?
Probably, I think a few days later. Depends on clinical of the patient as well. Okay, now we have to keep suction. At this time, even we cannot place the plastic stent with the echo endoscope because of a lot of fluid coming out. It still be fine because we can do it later with side view duodenoscopy. The important thing at this time is to try to aspirate the fluid as much as possible to prevent aspiration of the patient. Because sometimes the position to place the plastic stent with the echo endoscope, particularly in the upper half of the stomach, is not that easy. But with the duodenoscope, it's easier. So the next step, I'm going to place the plastic stent. First of all, I put the cap on to prevent leakage of the air. So then now I can suck effectively. And my assistant is giving me plastic stent, double pigtail. Now the introducer is coming. In this patient, for sure that we will do direct endoscopic necrosectomy later, probably several times until we can clean the things out.
Will you already schedule the next endoscopic procedure, or will you wait
maybe
for the
maybe 2 or 3 days we do direct endoscopic necrosectomy. But normally, before the direct endoscopic necrosectomy, we do image such as CT scan or at the very least ultrasound. You can see here that.
And can you just tell the audience again the reason for placing the double pigtail stent?
Yeah, the reason is that to prevent collapse of the wall of pancreatic necrosis, to place onto distal flange of lumen opposing metal stent, because that might cause some damage. Yeah. So I think at this time, look like a lot of fluid come. So very difficult that we do the plastic stent treatment. So the first thing, I'm gonna try to aspirate all the fluid out first, and then we can let back into the lamps and get into the lumen and place a double pigtail stent later. So let me aspirate all the fluid first. Okay. Yeah.
It's a beautiful demonstration. And
We have about 8 minutes left. I try to aspirate as much as possible, and then we may use the same scope or chain to the duodenoscope to place the plastic stent. Can you give me the plastic stent, the brand number, the envelope of the plastic stent? The plastic stent that we will use today, certainly it must be a double pigtail plastic stent, and the stent that we use today is Medical. You can see here, this is a Medical, and because of the lumen opposing metal stent diameter is very big, so then we can use 10 French double pigtail, and the length of the stent maybe 5 to 10 centimeter in diameter. It does bother much, yeah. And the technique to place double pigtail stent is the standard techniques of placing double pigtail stent while you're doing ERCP. And actually pushing the plastic stent across the lumen opposing metal stent much more easier because it's widely open. And you don't need to be worried if the plastic stent migrate back into a wall of pancreatic necrosis. You can simply push the gastroscope in and pull it back. Yeah. And in fact, actually, in the case with the wall of necrosis that we need to do direct endoscopic necrosectomy later, it may be today or days after tomorrow. Actually, it does not really need a plastic stent placement to prevent collapse, because it's not going to collapse and cause bleeding within 2 or 3 days. Usually, if you leave lamps longer than 2 weeks, that might increase chance of bleeding, but within a few days should be fine. So in this case, I decided to do just aspirate and try to clean the fluid, and probably we will do direct endoscopic necrosectomy day after tomorrow after the image, and we're not going to place a plastic stent for today because of a lot of fluid and at this time. Yeah. Would you agree with me, or any comment or any suggestion? We have still about 5 more minutes.
No, I think that is a very fair way to proceed. To first,
so you're going to take this one.
Really make a big difference. Can you just tell us, because I think it's not so clear, is this patient done under sedation or is this patient intubated? And what is your
actually, in our unit, we do the propofol sedation and the patient in the left lateral process. So now you see that we just kick the plastic stent out in the stomach, and we take all the wire, introduce it out, and first thing we try to eliminate and suck all the fluid first. This is the most important. We have a very strong team, and the patient is in left lateral position, and we prepare all the containers for fluid to prevent aspiration. But if you are not quite sure and you're going to do patient in the supine position, probably I would recommend you to better intubate the patient to prevent aspiration. But in our unit, we do on the left lateral position or sometimes prone position. So then we can do that. Yeah, and the incidence of the aspiration is very low in our unit. Yeah.
I did not see you sample the content. Do you normally sample the content for microbial culture?
Yeah, that's a good idea. Actually, we can do sampling of the fluid for sending of culture, particularly in patient with high-grade fever or infected pancreatic necrosis. But in this patient, he has just only pain, but that's a good suggestion. We will do the catheter to aspirate the fluid lumen later. But first of all, I try to aspirate fluid as much as possible, and we can send some in container for culturing.
I think that was an absolutely beautiful demonstration. Thank you very, very much for that. We're going
Thank you very much. Yeah.
Clear the content of that infected necrotic wall of necrosis collection. And I want to thank again Dr. Pandajai for his wonderful procedure and expertise, and also in laying out so clearly the steps that you follow. So, Alberto, I'm going to return to you and just see how much time we have until we need to do the next case.
Okay, all right. Thank you very much.
Very much.
Bye.
Bye-bye. Okay, so I will continue the next procedure. Procedure number 3 will be done by one of the world experts hailing from Hong Kong, Anthony Thieu. Anthony is very well known, and I will also ask Dr. Moon to moderate the session for us and to introduce Anthony. The procedure that will be done will be an enteroenteric endoscopic bypass procedure. So welcome, both of you, and we are looking forward to your cases.
Hello. Thank you very much, Dr. Lagi and Dr. Moe. It's great pleasure to introduce our friend, Dr. Anthony Thieu from the Chinese University of Hong Kong. He's a definitely rising star and sun in the interventional US. Now he's preparing very interesting case for us. Anthony, can you hear me?
Yes, can you hear me?
Okay, could you introduce today's your team and the case?
Yes, my team. So I am very lucky to have 3 young ladies, pretty ladies, to be helping me. You can't see.
Definitely. Pretty young lady.
Rachel is a nurse as well, and Xiaobei is our overseas fellow.
Hello.
So today we'll be doing a interesting case. The patient is a 74-year-old gentleman. Do you have the PowerPoint?
Yes, clearly.
Okay, so the patient had Meristic syndrome and then had a cholecystectomy, which was complicated by bile duct injury and hepatic artery injury, and a hepatic cholecystectomy was performed. After the operation, he had recurrent episodes of cholangitis, and after some scanning, we suspect a HJ stricture. Last week, I attempted a short type double balloon RCP, but it was a very long ruling, so I could not reach the HJ. But at that time, I also did a supplementary US, and I think I could see the HJ right next to the duodenum. So today, we're going to attempt a US-guided entero bypass and place a luminal pulsing stand so that I could insert the scope through the stand and reach the HJ for a subsequent RCP maybe next week. So for this procedure, there are several difficulties. One, we need to identify the HJ and then find the apron limb. 2, we need to distend the apron limb so that we could puncture with the US. It might be difficult because the apron limb is not distended and it's not obstructed. And then finally, we will insert a luminal pulsing stand. This is a cautery enhanced luminal pulsing stand. Today, we're going to use a new device. It's called the hot sewer system. It's by MITech from your country, Dr. Moon, Professor Moon. So with this new device, it's a endoscopist controlled delivery system. So
almost with hard edges, right? Almost with hard edges.
Completely different delivery system. Okay, I've already inserted my scope. Do you have the US image?
Yes, clearly. So any accessories and device for target intestine to be punctured?
The plan is to puncture with a 19-gauge needle, inject contrast, and then try to fill the apron limb with a water as well as the endocarmine, and then insert the stent.
Okay.
So right here you can see a little bowel, not distended. Okay, but if I trace it, I can trace it almost to here, right here. Okay. Okay, right there. Okay, so I think here it is one side of the bile duct. You can see some stones here. And then here is the other side of the bile duct. Here is the other side. And then perhaps the HJ is somewhere around here. Around here. So it's probably stenosed right there. So this is the apron limb. So I'm going to trace the apron limb a little bit backwards. Here is the apron limb. And maybe I will puncture around somewhere around here so that I have more distance to insert the stent. Okay, maybe around here. What do you think about here, this area, Professor Moon?
Looks very nice.
All right, can I have a 19-gauge needle?
So mixture of normal saline and contrast media and methylene blue. How about the CC? How the amount?
Well, actually, it's just by arbitrary, by feel. So a bit of methylene blue contrast, so you can see the limb. Okay, so I'm going to puncture now.
Can we see floor?
Yep. Okay, I think I'm not entirely in yet. Okay, yeah.
Usually, what kind of needle do you use for 19-gauge?
19-gauge Olympus.
Okay, EG3?
Yes, correct.
Nice option.
So I think I'm in the limb now.
Okay.
Yep.
Could you show more zoom in?
Sorry?
Of floor image? Could you show more bigger size of image of
X-ray
floor?
bigger. Mega X-ray. Okay, can we connect to a water pick? More. Imagine. Okay, I'm connecting to a water infusion system so that we can descend the loop out a bit. Okay. Yeah, sorry.
Okay, now can you see the bigger US image? Change?
There's an image, okay, sure. Oh, 5 to 30. Better now, yes.
Anthony, are there tricks to retain the fluid longer? Do you, for instance, use Buscopan?
Yeah, we give Buscopan now. Yeah, what's the other? Some empty plastic. Yeah, correct. Good suggestion. So nurses are preparing the Buscopan, and I'll keep infusing. What do you do? Okay, a little bit better now.
Anthony,
Yeah,
while
much better.
waiting for the Buscopan to work, is there a specific type of patient that you would select for this procedure? Or in contrast to using a single balloon enteroscopy ERCP, what is your practice? Or is this, if you can see the biliary limb, that is,
Yeah.
you decide to use this technique? How do you make
Usually,
that decision?
yeah. So for us, we have the short type double balloon device. So most of the time, for benign conditions, we will attempt the balloon enteroscopy assisted ERCP first. And if that fails, then we will consider a US approach. Okay, so Buscopan was injected. So yeah, so for this patient, you can see we're not distending very well.
For this patient, you already tried the enteroscopy, right? But
Yeah, I
failed.
really tried. I couldn't reach the lumen. So we'll see if we could distend the small bowel or not. But at the same time, because my wire is inside, my needle is inside, we could attempt to insert the wire and see if we could reach the small bowel and insert the stent along the wire. Oh my God, the contrast.
Okay, could you
right now,
explain
it's
what's the
not-
differences? Okay.
Right now, it's not distending very well yet. So the position-wise, for a EUSGJ, usually we have the patient sideways. But because the apron limb is on the patient's right side, so we have the patient on supine position. Okay. Now it's distending a little bit more. A little bit better. Okay, we have contrast.
Okay, any differences to performing US guided GJ-STOMY with this procedure?
Yes,
You
of
want to
course.
use the guide wire?
Yeah, so if the small bowel is not distending too well, I will use the guide wire.
Okay.
But let's see. So preferably, we should have the small bowel a bit more distended than now. It's a little bit bigger. But, I think for us, unless we're 100% sure, otherwise we should not move forward with the procedure. It's a bit more distended. I'll give it a bit more push. Okay. Okay. I think it's something easier. Oh my God, this is contrast. Right.
How about balloon occlusion method for this case?
Oh, for balloon occlusion, we need to have the guide wire in the a device in the proximal in the apron limb. So we need to insert a scope all the way down there first. I think right now it's a bit more distended. Maybe possible. Okay, just a bit more patience. I think that's move up. Only 50. So how much have we injected so far? 500. About how much? 50 to 100. Oh, then that's all enough. So usually we need to inject around 200 to 300 cc's of solution before the small bowel will be distended. So, okay, seems to be a little bit better. All right, a little bit better now. Okay, so at one moment, I think we are almost there. Okay, so have we opened the stent?
So you will do direct penetration without guide wire?
Oh, for this case, maybe dangerous. So I will use a guide wire to guide the insertion for this one.
You can use it because it's fixed after anastomosis.
Yeah, but the duodenum is not very distended. I think it's like that. So how much have we infiltrated? 200, okay. So we've only injected around 200, so I'm gonna inject another 100. So normally we would use, for a USGJ, we would insert a feeding tube, and then through the feeding tube, infuse the small bowel with solution, and that would usually be quicker. Right now, I think I'm seeing more distension now. I'm not sure if you would, I'm not sure if you would agree, but I think it's more.
It's better.
What's that?
It's a little bit better. It's not perfect, but it's a little bit better. 200. Okay, so I think this is the best we could do. So let's put in a wire and see. Oh, actually, my right?
I think you already used today's hot plumber stent, today's device. So how about comparing with hot axios?
A moment.
One suggestion from the audience is tilting the table with patient, like head down to have more distension.
Okay,
It's another good option.
we have the table a bit head down. Okay.
I think we're all mesmerized by your procedure and your skill. Can you just tell us what type of wire do you use?
It's a 025 angle tip, 025 angle tip 50 guide.
Do you require in this setting a wire that is slightly more stiff? Is that helpful when you introduce?
Usually 025 is good enough for us.
Okay.
I'm not sure if I could change the direction anymore. Let me see. Preferably, I would, okay.
Good,
I
good.
want the guy wire to be a bit more like this. Okay. All right, I think we have to settle for this. Okay, let's exchange.
Okay, like a small shoot assist.
Like a tiny pseudo assist, yes.
Very small.
Yep. Oh, wait.
We can see wire and dilated vowel on US. Very nice.
Yep.
So now Anthony trying to keep the direction of guide wire is very important on US. If you can see the guide wire on clearly on US, you don't need to lose guide wire.
Okay, my wire is around here, I think. Around here. Okay.
Yeah, we can see.
The other option is to try to puncture here, actually, because this might be a better loop. What do you guys think? But my wire should be here. Anyways. All right, let's insert.
Now you are inserting delivery system.
Yep, delivery system, correct.
It may be the first demonstration of by you of hot polymer stand. That device produced by MIT of Korea.
Yep. All right. So for this this device, so I'm not seeing my wire very well. I think it might be somewhere here. I'm not exactly 100% sure. Okay, but okay. So there are several systems. First, this is a unlock system to lock and unlock. So if I open this, unlock, I can push the delivery system forward. Okay.
Okay, Anthony, could you show the US image as a bigger? Could you change it? Yep, great, great.
Okay. All right. So if I push here, then it will push the delivery system out. I'm not getting a really great ultrasound image. My position may have changed a little bit. I think my delivery system should be somewhere around here. If I move forward, you can see me moving. Yeah, that's my wire. Yeah. Okay. Perfect. So the pushing is similar to axials. All right. I'm going to go in with hot. So I think I'm in. Ready? Okay. Okay. To deploy, I lock this first. I rotate 180 degrees here. All right. I open the stand slowly. Push here.
We see a large image of the fluoro.
Okay, I'm going to push the stand a bit deeper because I feel I'm not in a great position and I cannot see my US view very well. Okay, hold it. That's it. And I'm going to open my stand further. Okay. I open by here and I reach this area. You can see the stand partially opened. And I'm going to rotate again 180 degrees here, like that. Did you see that? And then I'm going to open my stand further. All right. Here, right now. Okay, that's the stand. Can you see that?
We can see that. We can see the distal flange.
Yeah, the flange.
Clearly, distal flange is on vowel. Yes, in
and then
vowel.
I'm going to pull back the stand a little bit. Okay, now I'm quite sure I'm in the lumen. I'm going to pull back some more. All right, so I think we are quite good. What do you guys think?
Great, great.
Okay, I'm going to open the remaining of the stands inside the delivery system. Okay, so the stand is completely open. And I'm going to change, I'm going to push the stand out. All right, so I'm going to change to endoscopic view for you. But you should be able to see the stand.
We can see that.
Yeah, right here, you can see the stand. And then it's completely deployed. Okay, so on X-ray, you can see both flanges, right? Okay, so can we use this? All right, good. Okay, can we leave the white?
Fantastic, Anthony. Fantastic.
Thank you, Professor Moon.
Usually, when could do ERCP?
So for this case, we will do it on Monday. I won't do it immediately because I worry the stand may dislodge. So right here, you can see the tip of the device came off, but it's okay. Okay. So I think it's okay right now. I'm going to pull out the wire.
Very nice, very nice.
Great. All right. Okay, the site is here.
Very nice. You made the second entrance to the biliary tree.
Yeah, correct. Okay.
You can be a
any
port
questions?
and access. Great.
Thank you so much, Anthony. That was absolutely a masterful performance and a very, very clear description of the case, as well as you taking your time to do this. So I want to thank you. I want to thank Dr.
Thank you very much.
as well for moderating this case. And I think we can then move on to the next case. Procedure number 4. Thank you so much. Bye-bye. Procedure number 4.
Bye-bye. Bye-bye. Thank you.
Bye.
Zeus IT, endoscopic ultrasound electrocautery enhanced delivery system. Zeus IT is an endoscopic electrocautery enhanced delivery system that creates anamosis between GI tract and target structure to place stent in the targeted location. Zeus IT is designed to shorten procedure time by penetrating the target location with one-step access. Insert Zeus IT over the guide wire and turn the luer lock clockwise to secure the delivery system to the scope. Then, connect the generator to the cautery connector. Verify the desired setting on the electrosurgical generator. Step 1. Positioning. Unlock the sheath lock and push the sheath handle to the targeted location. Make sure generator is on the recommended setting, pure cut, and push the sheath handle downwards under EUS guidance. Stop the sheath handle at the proper position. When entering is completed, lock the sheath lock and power off the generator. And unplug the cable from Zeus. Step 2. Stent deployment. To deploy the distal flange, rotate the spin lock 180 degrees. Deployment is ready when you see odd numbers of stent deployment indicators. Push it upwards until click feeling. Pull the endoscope back slightly to the wall. Make sure the black marker is visible under the endoscopic view. If the black marker is not visible, unlock the sheath lock and slide the sheath handle 2 to 3 millimeters upwards until the black marker is fully visible, and lock the sheath lock. To deploy the proximal flange, rotate the spin lock 180 degrees again. Deployment is ready when you see even numbers of stent deployment indicators. Push it all the way upwards. Check that the stent is properly positioned. Unlock the luer lock counterclockwise and remove Zeus IT. To remove the stent, pull the lasso on the stent by using alligator forceps or snare.
Good morning, Australia. Oh, good morning. It will be late evening already. Correct. We heard that you had an emergency procedure to perform, so thank you for still being able and being online now to present your talk on US brachytherapy, Dr. Nguyen. I will also ask Dr. Marco Bruno from Rotterdam to be the moderator for this session. So welcome both of you.
Thank you very much. I am very curious to your presentation, and maybe afterwards we can have a short discussion.
Okay, great. Thank you, Marco. Let me upload my talk. Great. Thank you for the opportunity to be part of this amazing symposium on EUS and showcase what we do in Adelaide, Australia. We're one of the centres that's actually quite interested in pancreatic cancer treatment, and over the last few years we have explored the use of intratumoral radioactive material adjunct to chemotherapy for treating locally advanced pancreatic cancer. We all know that radiations have been increasingly used because data actually have shown that it might make the survival different, particularly in the case of locally advanced pancreatic cancer. And this is probably be supported by the new modality of radiotherapy we call stereotactic body radiation, where it is actually focusing the target by fiducial marking. And this is how we do SBRT, or the focused radiotherapy. After placing fiducial, you can see that the tumor can be outlined, and using computer program, the radio-oncologist can targeting the cancer selectively and avoid damaging the adjacent organ. And this has actually been an increasing method of delivering radiation. However, it does actually have weaknesses, particularly the need for fiducial placement, planning CT, and certainly it can interrupt chemotherapy. And in real life, like our experience with SBRT, it can interrupt chemotherapy up between 2 to 4 weeks. Now, a new method of delivering radiation to the tumor very focally is actually to implant the radioactive material into the cancer. And this can overcome all the weaknesses of SBRT with minimal interruption, because you can actually do it within a day. And this particular agent actually originally come from Australia. It is phosphorus 32. The beauty of this agent is that it is in the aqueous form, where you can implant it through a needle. You can dose dependently determine based on the tumor volume, and it does actually have quite a long half-life, 15 days. So the treatment can actually have ongoing effects actually up to 2.5 months to 3 months. We're able to localize actually the actual agents actually on histology, and as you can see there, actually after the injections, even though we inject right in the center, we can see that these actually localize in the cancer and acinar cell. And at this point, we're actively looking how it works. Now, majority of the data that's supporting our work come from the PANCO trial, which is an effort between Australia, UK, and Belgium. And in this particular trial, we want to look at the impact of Oncosil in addition to either FOLFIRINOX or gemcitabine. And with the Oncosil, we were able to deliver about 100 guide to the cancer. Now, this is compared with SBRT. At the max, they can actually only deliver 45 to 50 guide. So this is actually quite an effective way to deliver very high dose focus on the cancer. With this particular trial, we only look at safety and tolerability, but we also have a look at the other outcome measure, which I will mention. And as you can see here, that in combined, they can uniformly reduce the tumor size quite effectively, up to 90% reduction in the tumor size. And this is also reflected by the reductions in the PET signal and serum CA99. So all of that's actually indicating that the treatment is effective. Our group actually have published our first experience with this agent, and what we are quite intrigued by is the ability of the combined therapy to downstage the cancer to resectable stage. This is all locally advanced, and we can actually downstage up in 50% of our patients, and of those, 5 actually went ahead with surgery, 1 were medically unfit for surgery, and of those 5, 4 out of 5 have R0 resection. So it's actually look quite promising. We also have seen this actually with the PANCO trial in 44 patients, a quarter downstage to resectable stage, and of those, 80% have R0 resection.
if we compare with actually the general population of pancreatic cancer, and this is actually based on Australian cancer registry, you can see that actually Oncocil plus chemotherapy, regardless whether they have resection or no resection, their outcomes still better than the overall locally advanced pancreatic cancer as shown in the green line. And certainly, if you're able to have combined therapy and surgery, the survival benefits actually between the two groups are quite marked. So this is basically the reason why we've been studying this agent in combined with chemotherapy for the pancreatic cancer in Australia or in Adelaide over the last 3 years. So I'm going to go through the next few slides on the preparation, because I think this is the most important part. You deal with radioactive material, so contaminants of the radioactive material, particularly with a long half-life, can bring your unit down. So we line our path of injections, the floor, just in case of any spillage. We make sure that we have the radioactive waste bin beside our scope, so that once we pull it out, we put it immediately into the waste bin, avoid any spillage at all. In terms of the radioactive material, the Oncocil, it comes in a syringe, and they are transported in a glass-leaded box, so that avoid any spillage or radiation. We do have a Geiger counter to make sure that we check that there's no spillage, which I'll show you a bit later. Now, this is the way that we prepare the Oncocil. So it is in up to 3 ml syringe, and the actual syringe is protected by another lead line protector, and we use a 3-way tap with a saline flush. So this is to avoid detachment of this radioactive material syringe and avoid spillage. So we just use those 3-way tap to flush the material through the needle, and then flush the material out of the needle using normal saline. Because this is a beta ray, which only have about 5 centimeter active path, we do not need to wear lead gown. In terms of the determination of how much you inject, this is based on the tumor volume, and it's at this point it is 8% of the tumor volume, and the amount we inject should equate to about 100 Gauss. We use a CT scan volume determination program here that take into 3 dimensions of the lesion. We arbitrarily determine how to implant the material. If the lesion is less than 3 centimeters, then we do a central or a single implantation. But if the lesion is bigger, between 3 to 6 centimeters, we will try to do a tracking implantations with 25 in the distal margin, 50 in the center, and 25 in the proximal margin. So I'll run this video on a case that we recently done on a patient. We have locally advanced pancreatic cancer. We presented with about 2 weeks history of jaundice, pancreas jaundice, and we found on previous videos that we have had a pancreas lesion that involved the borderline. So we see that we're involved in the trial that looking at the use of Prothronox and Oncocil. So we completed 2 cycles of Prothronox, and now here we have the Oncocil implantation. So we have a pancreatic mass here that selectively obstruct the biliary tract. So we use the message here of obstructing the bile duct, and they use a plastic stent. So after the stent that we there, this is the dilated part of the proximal bile duct. So the pancreatic cancer is here. The reason that we watch here, we locally advanced is that there's a little bit of portal vein involvement in this region here, right here. That's disposing of the irregular on the portal vein area here. So that's why, okay. Yeah, so I think it's important that we deliver some Oncocil in this area here to peel it away from the vessel. It's quite nice. You can see that the normal pancreas is very bright, and the cancer itself is quite dark. And I think if we can find under contact with the better method that we can do it. We know better where we find. So for implantation, we use a 22 gauge strain tip. So my preference window is the full 22 tip. So we don't actually flush the needle with anything, so we just have a normal needle. There will be air that will be flushed through once we do the injection. Okay. You can see the tip of the tip will come out right here. Okay, so you can see the tip is here, and I'm going to inject under one side guide. The tube is quite hard. So once you get right up into this end over here, okay, I would say we take the whole 1 needle. We come and go to the distal part, and then when I pull back a little bit, we flush with 1 needle or 1.5 needle. Yeah. Okay. Right. Start it out. So this part of the injection is crucial. We have the 3-way test that we do control our injection. So first, let me yeah. Good. Okay. Second, let me do the needle back. Okay, you can start now. Okay. Okay. So this is exactly the magnifications of the view that exactly will block by the injection. So you can see with the injections, air will come out and it will obliterate the distal margins of the tumor by that 1 mil oncoseal, and the needle will slowly retract, and a saline flush will be performed to remove all of the oncoseal inside the cancer. Now, once we have injected and we're happy that we have flushed everything out, we pull the needle back to the sheath, but we do not pull the sheath back into the scope to avoid contaminant. I normally put the needle out again in the stomach and flush with saline to make sure that we see only water come out, knowing that we have injected all of the oncosil in the tumor itself. And then we pull retract the needle back into the sheath and pull the scope out.
Then we cross the channel, make sure that all any contaminant will be out of the scope. We flush out 200 ml of saline or water. And then that brings it scope.
So this part is vitally important. That's the scope and the endoscopists we are free of any radioactive signal before we put the scope into a cleaning room. We uniformly book the patients for a BREM scan, which to check that our radioactive oncosil is localized only at the injection site. This is very useful as a feedback to the endoscopist, but also to make sure that we have an effective implantation. You can look at any contaminant or the spillage of the material in the rest of the gut or the outside of the tumor using this scan method. So I think if you're keen to take on this type of treatment, there's a few key take-home message. Your unit must have a well-supported nuclear medicine unit to work with you. For me, I think the utmost important factor that you have to be care of is preventing contaminant to your room, your equipment, and your scope. Because of the long half-life, if you contaminate your scope, that scope will be out for 3 months. So I think you must have a radiation safety officer to check the scope and all of the equipment before we stop the procedure and clear the room. We should have a way to determine the tumor volume. It is essential so that you can determine the implant volume. The pattern of implantations, I think at this point is debatable, but I think if you've first started a single implantations in the center or where you think is important, would be ideal. And you should ensure that the needle flush with saline because of the dead space of at least 1 mil. And doing the brain scan, if you have the capacity, is to us is very helpful and important to clarify that we have effectively implanted the therapy. And at this point, oncosil implantations is only indicated for locally advanced cancer, and this has to be in conjunction with chemotherapy, either for FOLFIRINOX or gemcitabine. So thank you for the invitation, and I would be happy to take any question now.
There are a few questions. One, you said something about the distribution of how you inject the material. When a tumor is less than 3 centimeters centrally, when a tumor is bigger, you have multiple spots. One issue, of course, if you have vascular invasion or you are afraid based on CT vascular invasion, that is the spot that you want to try to treat. On the one hand, you want to target that spot. On the other hand, what is the risk if necrosis happens that you get a vascular event in the patient?
Yeah, so I think we check the vascularity of the cancer before we inject very carefully. And usually, as I shown you there, I now do contrast EUS to look. And with contrast EUS, you can see the vascular area very nicely. Now, injecting the necrotic area might not be that bad. It just harbored a focus for the radioactive material to work. But inject into a vein or vessel could be potentially important. But in fact, with the Panko trial, there's one case that's inadvertently injected, not by our unit, injected into the varices. And you can see that the trace go up to the lung. That patient were monitored for 3 months, and there's no consequences of the intravascular injection there. But it is important as a learning lesson that we either avoid doing injection in the setting of large varices and screening for a vascular pattern within or surrounding the tumor is important. And that's why I have moved toward contrast EUS and implant using it actively at the time.
And so in case of a tumor bigger than 3 centimeters and with attachment to the portal vein, how close to the portal vein would you place your most distal depot of the material?
As I showed you there, within 5 millimeter, I wanted to get quite close to it. So that particular case, the portal vein involvement is not as marked as the very first time because patients we already have 2 cycles of FOLFIRINOX, but we try to get in within the 5 millimeter.
So how many patients have you now treated so far?
We've treated about 37 patients in our center, and this new study, we're looking at the pathophysiology of the therapy.
Any adverse events, any spillage of material that you saw after the procedure?
So far, no. But as I said, with the Panko trial, we have that one case where we see the intravascular injection.
Okay. Now, you stated about the way you choose the volume of injection. It's about 8% of the total volume of the tumor, which in a tumor smaller than 3 centimeters, only like a milliliter or something?
Correct.
Yeah.
Correct.
What is the maximum amount that you've injected in the patient so far, in volume-wise?
So the max is toward the 6 or 6.5 centimeter, and the maximum volume that we have injected is about 3.5 mil of oncosil.
And there you have no problem getting material in with regards to viscosity and the desmoplastic appearance of the tumor, which is quite firm. You are able to, within the depots, to deliver the material.
Correct. So it's always hard, and that's why we have to make absolutely sure, because with our very first fill, we learn exactly as we do this procedure. Very first fill we inject, and then we tend not to flush too hard. And when we pull the needle out and flush, we still see some of the oncoseal that have been flushed out of the stomach. And that's why a Brem scan will tell us that yes, we did have some. Then we try to flush as much as we can, usually up to 2 ml, and that we overcome that problem.
Okay, there's a question from Gloria Westphal on this, and she asked whether this therapy could damage either the plastic or the metal stent that is inside you. Is there any concern that you might have?
No, I mean, in total, at most we will. I mean, in a big tumor like 6 centimeters, 3.5 plus another 2 mil of silent flush is 5 mil. That's still relatively small. For majority of the cancer that we're dealing with is about 3 centimeters. So we inject about 1 to 1.5 mil. Flush with 2 mil, so it's roughly about 3 mil that we inject. Definitely, we have not seen any busting of stents or rupture of tumor as such. No.
Okay, great. There's some questions about, and you kind of eloquently showed that, your precautions with regards to the contamination of your instrumentation, but people have some concerns with regards to that. Did you have any adverse event in that regard? Did you have any contamination of your materials to which you had to act and to had to kind of deactivate the instrument for a few weeks, a month?
No. So that's actually the first thing that I work with the nuclear medicine department. That's actually because the implication is just not just the scope. If you actually contaminate the scope and you put through your main cleaning system, then you contaminate the whole cleaning water system. So that's absolutely vital. If you want to start, then you have to work with your nuclear medicine to make absolutely sure that you will not contaminate your scope and put it into the main system. Then you ruin your whole endoscopy.
Okay, and with regards to the outlook of the future, you have done now quite a few cases. With regards to what you have learned and what you would like to change in the future with regards to the technology, to the therapy, is there anything that comes to mind?
No, I think it's promising, certainly now in our hand, particularly with the downstaging of the tumor. And I think with the aqueous form of this material, it just allows us to tailor the dosage more accordingly to the tumor volume. And I think with more further study, bigger study, I think this might be a very useful adjunct to locally advanced pancreatic cancer.
Right. So do we still have time?
Sorry?
I'm asking Saul if we still have time.
Oh.
So we have to unmute.
I think we still have a few minutes, so please continue, Marco.
Yeah, okay, well, there is still a question with regards to the risk of the therapy by Deb Manjumdar. And there's this question, and I already alluded to this. If you deposit the material very close to one of the vessels, the reaction might be that necrosis starts to occur. Is there any risk, is the question, that you would anticipate a serious bleed in that particular area?
No. Well, I mean, I think, look, the PANCO trial have 44 patients. In addition to PANCO's trial, we did an additional probably 30 cases. And our colleagues in New Zealand, Dr. Wilder, we have done 18 cases. And so far, we have not seen any complication related to intratumoral bleed. And we have examined the histology of our resected specimen. So so far we have about 10 cases, or we actively review it because we want to look at the distributions of the oncoseal in the resected specimen and pay particular attention to any intravascular bleeding or fibrosis. I mean, that's quite a concern to the surgeon. Some of the surgeons are concerned that if we inject, it might cause more fibrosis and impair the techniques of resection. In fact, so far, our surgeon did not have any problem, and we do not have any intratumoral bleed.
Great.
I think we'll have to stop here, Marco. Thank you so much, both of you, for this excellent presentation of a new technology that I'm sure will find its place in the management of pancreatic cancer, and Marco for so excellently moderating the session. So we'll move on to the next session, and Alberto, will you introduce the next speakers?